Good evening, everybody, and welcome to our series of AIG Hospitals International Endoscopy Symposium. This evening, we have a very important symposium on endoscopy technology. In fact, in the last few years, endoscopic technology has improved so much that enhanced imaging has become a part of our daily life. This enhanced imaging keeps improving every year, so that we now have a capability to diagnose very early lesions, especially very early cancers, and not only diagnose them, but because we have this ability to remove them endoscopically, this becomes a very important aspect of endoscopic diagnosis. So to talk on these new areas, what modern endoscopic advanced imaging can offer, we have three very well-known speakers who are going to talk to us, and what I'll do is, as we come to each speaker, I'll introduce them and then we'll go on. Our first speaker is Dr. Krish Ragunath. Krish is currently the Professor of Medicine and Director of Research at Curtin Medical School at Royal Perth Hospital in Australia. He was earlier in the UK, was very active there. I think everybody in India and Southeast Asia knows Krish. Not only was he visiting here for several of our conferences, but he's also the chairman of the research at the World Endoscopy Organization. He's done a huge amount of work in enhanced imaging, especially with Barrett's esophagus, and used to run his very successful course in Nottingham earlier in UK. Of course, since he's moved to Perth, things are a little more quieter there, but I think it's a delight to see Krish back again on the screen here. Krish, thank you very much. And Krish is going to talk to us a transition from white light endoscopy to image enhanced endoscopy. Krish, we are waiting to hear you. Thank you.
Thank you very much, Nagi, and good evening, good afternoon, good morning to everyone globally who are listening. I will start the screen share now.
Yeah. We can see that, Krish, now.
Yeah, okay. Thank you. So the first slide is my disclosure. So now we are talking about what we can see in the current generation of endoscopes. But I think it's important we need to look back a little bit to how we started and how we ended up where we are now. So you can see on the left side of the screen here, in 1868, that is Adolf Kussmaul demonstrating rigid endoscopy in a professional sword swallower. It has taken nearly 100 years for us to move from that to, on the right, where you are seeing Basil Hirschowitz doing fiber optic endoscopy in 1965, using a fiber optic scope. So it has taken a long time for us to move from the rigid scopes to fiber optic scopes. This wouldn't have been possible without the invention of the fiber optic bundle. So this person is Professor Harold Hopkins, who hailed from Leicester, which was not too far from me when I was in Nottingham, and he was a British physicist. So he was one of the pioneers in the initial invention of the fiber optic bundle, which later on went on to the production of fiber optic endoscopy. So I think we need to credit a lot for those people who has really made us to appreciate what we are doing in endoscopy now. And I was also privileged and happy to say that the 2010 Hopkins Award in Britain, I was able to get the preaching from Peter Cotton. So now moving on from this, let us see what we saw in the 70s and 80s. This is a fiber optic view of a short segment of Barrett's esophagus as seen with a fiber optic scope. You can see a bit of a blur there, a bit of a tongue of Barrett. That's all you can see there. So in the 80s and 90s, we've moved on to a video endoscopy, and you can see again Barrett's esophagus. You can just about see the Z line there and the hiatus hernia in the center of it. And finally, in 2000 onwards, we are now seeing good quality endoscopic imaging, especially high definition endoscopy. So this is a good transition, what has happened in the last 20-30 years. So whilst we have been doing this, the Japanese have been using other technologies there and trying to enhance the white light endoscopy. So this was one of the first reports of individual dye spray in 1975 by the Japanese group looking into early gastric cancer. So So those days, what was happening was different form of dyes were used to enhance the mucosal visualization, and various dyes like toluidine blue, methylene blue, etc. was tried. Indigo carmine is good in the sense that it doesn't get absorbed. It is a contrast dye, so that it is a plant extract. It's not toxic, so it gets accumulated around the crevices, and then it enhances the edges. So this has been something which has been happening over the last 20, 30 years, and many of us have been used to it. So following on from this came in the Lugol iodine dye spray in the early 90s. So this was one of the first reports from Sidney Chung's group in Hong Kong, looking into a squamous dysplasia in patients with head and neck cancers. So how does this Lugol iodine work? Lugol works in a different way. It is more of reactive agent, where when iodine is sprayed on the squamous epithelium, the glycogen, with the normal glycogen, it is glycophilic, and it becomes triiodide, resulting in a golden brown pigmentation, which you can see at the periphery here. But when there is dysplasia, the glycogen is lost, and so it becomes Lugol void. And you can see very well in the center where there's a large patch of the squamous dysplasia. So the accuracy in diagnosing squamous dysplasia is nearly close to 98-99% when you're using Lugol iodine. The problem with Lugol is obviously it is an irritant, and it can cause allergic reactions as well. So now moving on from the esophagus, the Kudo pit pattern classification was brought in by the seminal work done by Kudo and colleagues in Japan, and using the indigo carmine dye spray, and then subsequently using crystal violet as well, looking into high magnification. Now, the Kudo classification is a standard classification, and many of you doing colonoscopy will be still using this classification to differentiate between hyperplastic polyp and adenomatous polyp, and then invasive cancer. So this technology has been around for a while, and many of us have been using it. The advantage of using endoscopy, it not only helps to identify the lesion, it also helps to delineate the lesion and characterize the polyps. Say, for example, this is a rectal polyp, which you can see way back. I was doing in 2006, one of my first endoscopies. This was a flat polyp in the rectum. The problem was this patient had previously had a polypectomy, and you can see there is a central scar on the white light image, and it was removed. But when the pathology came back saying that it was not completely removed, when I went back in, had a look, then I realized that this is a large laterally spreading granulomatous polyp with a polypoid component which was snared off, and you can appreciate that on the right screen with this endoscopy with the indigo carmine. And this patient went on to have an en-bloc resection following this. So this has really opened up the eyes for us, especially in the West, looking into flat and subtle lesions, which we were not able to see before enhancing the images with these sort of endoscopy. So whilst we were doing all these things, working on various dyes, a real breakthrough happened in image enhanced endoscopy in around 2003. And then came the narrowband imaging. This was possible because of Olympus engineer Dr. Gono, who had worked along with Professor Ken Chiowo, where we spent a lot of time working with narrowband imaging in the prototype scopes. And what exactly happened was that they probed the white light endoscopy views and moved into image enhancement using electronic endoscopy, the way that the wavelengths were manipulated and filtered so that you can see the superficial vessels and the pit patterns. This happened because, as you know, in the standard white light endoscopy, you have the three primary colors, red, green, and blue. And these red, green, blue have specific wavelengths. Say, for example, around 400 for the blue, 500 around green, and 600 plus for the red. So if you block off the red, which penetrates deeper, then you can highlight the superficial layers. And that is what you're seeing on the right side of the screen, where you're seeing a tongue of Barrett's esophagus and with magnification, and you can see clearly the pit patterns, and you can also see the microvasculature there. And this is possible with just a click of a button, and then it separates out the filters. Now, narrowband imaging is very well established in the esophagus. This is a long segment of Barrett's esophagus, what you're seeing here, and it clearly shows a Z line which is moved up here. And then now can also be used in the squamous dysplasia. So this is a very good image of squamous dysplasia in a patient in the mid-esophagus. One of the interesting aspects here is that you can see right in the middle of the screen, there is an area of invasion, and you can see with the near focus, the pit patterns are gone, and you can also see the abnormalities in the IPCLs. So this is a very good example of how you can use image enhancement without using, for example, in this particular case, leukocytin to visualize squamous dysplasia. It has been also used in the stomach. There's an early gastric cancer. You can quite clearly see the demarcation line and the flat elevated lesion in the gastric body. Previously, we used to image these things with indigo carmine dye spray, and now you can do it just with the flick of a button with narrowband imaging. When you use high magnification, you can see closely the vascular changes, and you can see the distortion of the pit patterns. This has been applied to in the colon as well. You can see there's a flat, laterally spreading, non-granular, smooth type of a polyp, which is very well seen with narrowband imaging. So clearly now we have a various classifications for this, the Bing classification for the Barrett's, we have the Japanese Esophageal Society classification for the squamous cancers, we have the VS classification for the early gastric cancer, and then the JNET and NICE classifications for the colonic polyps. So, but one thing what you can appreciate in these images is that the images are slightly different from the color and the texture. You can see the difference in the extreme left, which I have used the 290 series of endoscopes when I was in Nottingham, and the one next to it, the squamous, was taken with the 190 series here in Perth, so that you can see the difference in the color there. And then the gastric one, which is seeing the third one, it was again taken using the 260 series gastroscope, and then finally in the lower down again a 290 series. So although these are all narrowband imaging, they all have different colors and different textures. So that has always been a bit of a bugbear for us, because you're not always seeing the same sort of images when you're doing this, especially when you have two different platforms with 180 and 90 using the RGB system and the black and white chip. So to move this forward, the Olympus has come in with this new platform, which is called the EVS X1 platform, which has amalgamated these two into one common platform. And I think it's something good which has come out now, so that we will have one standard quality of imaging. The most important thing what has happened here is to improve the quality of the white light imaging. And instead of using xenon lamps, in this particular platform, they moved on using LED lights. And it's not just one or two, it's 5 LED lights, so which makes it really very powerful and very bright. The advantage of using LED light is that it can last for hours together. For example, xenon lamps would last for about 300 to 500 hours, but the LED light can last for even 10,000 hours, which means that the lifetime of this process is going to be long time without the need for changing or even the power going down using LED. So here you will see that the white light, the violet seems to be the primary one, which is illuminated, and then you have the blue, green, amber, which is something which is new, has been introduced, and then the red. And again, they all have their own frequencies, and you can manipulate it with the filters with the switch off button. And more importantly, this is projected on a 4K monitor, which is a really good super high definition imaging what we are seeing. So what has happened here now because of the use of this is the quality of the white light endoscopy. So the thing what has moved on here with the white light endoscopy is the enhancement of the imaging, or the texture and color enhancement imaging, which is called the TXI. This has always been present in our endoscopes, but we were not able to really appreciate and differentiate and use it in a way of what we can use it now. So in this screen on the left side, you are seeing the gastroesophageal junction in an upper GI endoscopy, where you are seeing a very soft image. It's a normal image. And then on the right side, if you switch it, you can see it improves the contrast. You can see the pit patterns quite clearly, and you can also see the Z line quite clearly. So this is just with the flick of a button, you can increase the contrast, and you can see structures which you want to see. And if you do not want to, if you have a soft endoscopy imaging, you can just continue with the normal mode. On the right side, you can see that there's a long segment of Barrett's. Again, you can see the narrowband imaging, which is quite bright, And even without any magnification, you can see the subtleties in the mucosa, the pit patterns, and the vascular changes. So I think this is quite an important step forward. What has happened now in imaging, and even the quality of the white light imaging is so good that it will be hardly possible to miss subtle lesions. So there is one other feature which has happened in here is the addition of red dichromatic imaging, or the RDI. So these are all based on the processes. So the advantage of using RDI is because of the introduction of the amber LED, which improves the reticular reproduction. And as you can see on the right side in the image, when there is a bleeding, you can see that once you switch on to the RDI, it shows you exactly where the bleeding point is. So it is important not only that you're using good quality imaging when you're doing a diagnostic endoscopy, it also helps you when you're doing therapeutic endoscopy, especially when you're doing endoscopic resections, EMR, or ESD, and it can also help you when you're doing endoscopy or GI bleed. So again, we have used image enhancement to enhance the way we do a therapeutic endoscopy. I think this is something to look forward to since we will all be able to use it in the near future. Now let us see what has happened from the endoscope point of view. So the ones what I told you earlier on, the TXI and RDI, are based on the platform, based on the processor. But now the few things that happened in the endoscope as such. So one of the things which has moved forward here is the way how you see your endoscopic view and the focus. It's called the extended depth of field or focus, which means that you are able to see a larger area still within good focus. This is possible because of the imposition of 2 or 3 focal images into one and merging them so that you can see an extended view of a good quality focus. Another thing which has happened with the new generation scopes is the near focus, which has gone even better. So those of you who would have used a dual focus from the Olympus endoscopes would have seen that once you switch on a button, your focus comes closer, and when we do that, it comes to about 2 millimeters, which means that it magnifies to close to 70 times. But now that has gone to 1.5 millimeters, which means your magnification can go even up to 80, 85 times with just a press of a button. And that allows you to visualize close-up areas. And also you can switch back to see a broader view like the extended depth. So these things are, although small advancements, will make a huge difference when we do real-time endoscopy. Now, these are the advancements which has happened recently, and it's quite exciting to be in the endoscopy world now to do these things on the Olympus front. Now, I'll talk a bit about the Elixir technology from Fujifilm, which has been around for the last couple of years. Fuji were the first to introduce the LED system, and that really made a huge difference to our white light endoscopy. So the LED system consists of 4 LED lights, and you can see the primary colors where you have the red, green, and blue. In addition to it, you have the violet. And again, you can use technology to filter off the red light or the green light so that you can see the superficial mucosa quite well. And you can still manipulate the wavelengths in this system. So the blue light imaging, or the BLI, is such system from Fuji. It's in Japan. It's called the blue laser imaging because it is the laser light which is used instead of LED, and hence it's called the BLI, or the zero system. But in the rest of the world, we are using the Elixir system, which is the blue light imaging. So the images what you get with this are quite clearly higher definition, and also you can get more clarity when you use the BLI. It has also got another imaging mode called the linked color imaging, or the LCI. So the LCI is essentially a post-processing. What happens is, as you can see in the figure lower down, it tends to split the red and green and blue so that it improves the contrast of the view. So it is good to look at this when you're, and it's also pleasing to the eye because it is quite bright and also identifies subtle changes in the color of the mucosa, as you can see. I'll show you an examples of a few of this. So this is the blue light imaging in Barrett's esophagus. You can see quite clearly the Z line in the Barrett's, and you can see a long tongue of Barrett's, and you can see quite clearly the pit patterns as well. This can be used along with the LCI as a multimodal imaging technology. So this is a patient with Barrett's esophagus. There is an irregular T-line there. You can see an island of the Barrett's on the left, on the right. Once you put the LCI mode, you can see the pink mucosa there. So that's quite a non-dysplastic, uniform-looking mucosa there. And when you zoom in, you can switch on to BLI and you can see the pit patterns in close quarters. The one advantage with the Fuji endoscope is that you can go step by step with your zoom. For example, if you press once, you go one step ahead, it goes 30 times, and then you press again, it goes to 60, and then 90, and then you can go up to 130, 135 times the zoom. So you can do it according to your preference and how you want to do it, how you want to image things. So generally, with 1 or 2 zoom levels would be good enough to see good quality images. Now, in the same patient, I'll show you a place where there is dysplasia. Here, you can see that there is on the right screen there is a purple. The pink color is just distorted. It is not as good as what we saw before, and you can see with magnification the distortion of pit patterns. And this was an area of dysplasia. So you can use this in a combination of white light with the LCI and PLI, and it can aid diagnosis and treatment. So that's a good technology to be using it, and there are clinical trials up and running, which will be interesting to see. Now, we have a few classification systems. This is the blink or Barrett neoplasia based on blue light imaging done by Pradeep Bandari's group, and this is being validated now, and it's based on the pit patterns and vessel pattern, color pattern. Overall accuracy is 95% when used by experts, and it will be good to see how it is validated in clinical trials. It is also used in squamous neoplasia, BLI and LCI. This is a good example. You can see the white light and the LCI and the BLI, and then when you magnify it, you can see the distorted IPCLs. It is now compared with NBI, and accuracy seems to be somewhat similar, and in fact close to the accuracy what you get with Lugol chromatoscopy. So instead of using Lugol, you can use NBI or the BLI for squamous dysplasia. Similar thing has happened in the colonic pit pattern world, and this is a basic classification just about published a couple of years ago from the European group, and it has been recently validated as well. One of the interesting aspects about using LCI is, can this be used as a detection mode? So this is an interesting study, a quantitative assessment of the changes in color and contrast, looking into computational methods on the areas between the abnormal color, which is the flat pitch there, flat polyp there, with the BLI, LCI, and chromoendoscopy, and you can see that the contrast with the LCI and the chromoendoscopy are almost equal on the right screen. But there has been one study which has compared directly NBI with the LCI, where the NBI seemed to perform better, but we need to make a note that the NBI withdrawal time was longer than the LCI, and overall the miss rates were more than 20% in this particular study. And I noticed that the study was done by both experts and junior people. So I think it's important to look for further data coming out to see whether LCI is a good modality for detection. Now I'll finish off with a few words about the iScan optical enhancement system from Pentax. It is again somewhat similar like the Olympus and the Fuji systems. It is a combination of light filtering as well as post-processing, and they have improved on the previous surface enhancement iScan 1 and 2 with the optical enhancement. So the optical enhancement is somewhat similar to the NBI and PLI. This is a work what we did in London with Rehan Hydri's group, and you can see the accuracy is only about 89%, and I guess that these things will improve as the technology improves with the iScan optical enhancement. This is a simple classification which was done by Marietta Iacucci from Birmingham with collaborators in USA, looking in the iScan for the polyp classification called the simple classification colonic polyps. This has just been published and validated. Hopefully there will be more data coming out using the iScan as well. So finally, in summary, I think there's been a rapid advancement in image-enhanced endoscopy in the last decade, which we have clearly seen. All manufacturers have IEE features built in as a standard. So I think it also aids lesion detection and characterization in ideal conditions. But importantly, most of the data has come from expert centers. I think training and practice is crucial. It's important if we are to reproduce these excellent results from expert centers. Thank you for your kind attention.
Thank you, Chris, for this very nice talk on the recent advances in technology in endoscopy and all the image enhanced technologies that are available currently. So what we'll do is we'll take questions all at the end of all the 3 sessions. So we'll go to the next speaker. Our next speaker is Dr. Mohan Ramchandani. Mohan is currently the Director of Interventional Endoscopy at the AIG Hospitals. Mohan is known for his research in the area of third space endoscopy and also in enteroscopy. Is published widely in this area. He's also passionate about ESDs and all the other endoscopic techniques. So he's going to speak to us now on high magnification endoscopy and endocytoscopy. Mohan?
Thank you, Dr. Reddy. Chris has almost covered he has given a broader overview of what is available, and I'll be going to specific about what high magnification endoscopy is and how it is helping us to diagnose and help us in planning the management of diseases. So I'll be covering use of high magnification endoscopy in esophagus, stomach and colon, and also I'll touch upon endocytoscopy. So as we were talking about zoom endoscopy, which is a magnification up to 150 times, basically the zoom is of 2 types, either an optical zoom, which is achieved by using the endoscopic lens, and it magnifies the image of the target while maintaining the image quality. While the digital zoom is achieved by cropping and enlarging the image once it has been captured by the endoscope, like post-processing, but ultimately you will decrease the image quality. So it's always desirable to have optical zoom, and this can be achieved by the zoom endoscopes which are available. Unfortunately, this is the zoom endoscope, which is the optical zoom endoscope, available only in 200 series Lucida platform, maybe in Japan and UK, where we can use a zoom lever and focus upon one particular area and achieve a zoom of around 150 times. While we and other countries have a dual focus, which Chris is also talking about, where this is a unique innovative optical dual focus functions, allowing a magnification around 45 to 70 times depending upon how close you are going. As he was talking about 1.5 millimeter, which we can go, but this is the dual focus 190 series, where we can go around 2 millimeter close, and this achieves around 70 times magnification. So both of these zooms requires a hood to be placed. More importantly, in optical zoom, in a zoom scope, where you can apply this black hood, which is made up of silicone rubber, which is a soft cap, which does not traumatize the mucosa, because as you know, if you traumatize the mucosa, there will be bleeding and then the study will not be proper. And this also maintains a proper distance between the endoscope and target lesion to achieve the good focus. So this is a must once we are doing. So let us see what we can do in esophagus. As we know, the esophagus cancer, the prognosis depends on how early you are diagnosing, because if you are diagnosing the cancer early, that is in the phase where the tumor has not penetrated the muscularis mucosae, the chance of lymph node metastasis is almost 0%. And as you see, as the tumor has touched the muscularis mucosae or it has gone into superficial submucosa, the chance of lymph node metastasis are increasing. That means you have to diagnose these cancer in a very early stage, and this magnification endoscopy allows us to study these IPCL. These are intrapapillary capillary loops, which are tennis racket apparent superficial vessels, and as you can see, the cancer is developing into the epithelium. These are getting thickened and elongated. Basically, you have to catch the 4 morphological changes in these IPCL. They starts dilating, that they become tortuous, and they change in caliber, and they become of various shape. So you have to by NBI can catch this area even with the detection. You can have a detection by NBI, and you can see a color change because of the proliferation and increased number of these IPCL. There is a color change. So there is a color change of background mucosa, and once you detect that, you have to characterize by going very close to this and apply the magnification endoscopy to catch these changes. So as the cancer is going deep, you can see the changes in the IPCL. These are dilated tortuous IPCL, and once it goes to lamina propria, it gets elongated, and once it touches the muscularis mucosae or goes superficial submucosae, the loop starts opening and they starts communicating with each other. So by mere seeing, you can say that that cancer which is there, whether it is there or not, and if it is there, then whether it is gone beyond the muscularis mucosae in superficial submucosa or not, can be easily seen by this magnification endoscopy. So basically the NBI allow us to detect, and then we have to differentiate by magnification endoscopy based on the NBI characteristic. And as you can see, the white light endoscopy, you are barely seeing anything, and once you switch on to the NBI, you can see color change. And then I'll show you one of our video here. By just switching to NBI, you can start seeing this color change, that this is the brownish area, and then once you see that brownish area, you have to apply this near focus, go very close to this, and you will be able to see these IPCLs which are dilated, tortuous, and some of them are getting elongated. So it is quite clear that this tumor is at least in lamina propria, but yet it has not gone into the submucosa, so it is very well resectable. The lymph node metastasis may be around 0% in these cases. So by seeing this, you can decide, and there is no need to worry about the zoom scopes or dual scopes. And this is one of the study which has clearly shown that the 190 series scopes are almost equal. This is a non-inferiority trial comparing the dual focus 190 series scopes versus the 260 series scopes, and both were equally effective. So, and magnification endoscopy is definitely useful in catching the squamous cell cancers of esophagus, which is a predominantly form of cancer seen in this part of the world. We are also now seeing the Barrett's esophagus, and we have experts available already with us. And this Barrett's esophagus is basically because of the prolonged reflux. There is development of intestinal metaplasia, that is Barrett's epithelium, and then it progressed to dysplasia and adenocarcinoma. And once you see the Barrett's epithelium, you need to screen them, and if there is a surveillance required for dysplasia. So it is important for us to do the surveillance, and the shortcomings of present form of surveillance is that dysplasia may not be visible with white light endoscopy. The dysplasia is patchy within the Barrett's epithelium and can be missed by random biopsy, and adherence to Seattle protocol, which is a cumbersome process, the adherence is very low. So we have many, basically 4 types of classifications available. 3 of them are with high magnification endoscopy, the Kansas, Amsterdam and Nottingham, while the Barrett's International NBI group has come up with the dual focus classification. Basically they divide the dysplastic and non-dysplastic epithelium based on whether the NBI and magnification NBI characteristics are showing the surface pattern, which is round pits or regular with regular microvasculature, which is suggestive of normal epithelium. And as the intestinal metaplasia develops, there is development of surface pattern of villous and rich pits, and then as the dysplasia develops, this surface pattern become irregular and the microvascular pattern becomes irregular. So with this, the Barrett's International NBI group, the accuracy rate is almost 92% in picking up in differentiating between the non-dysplastic Barrett's versus the dysplastic Barrett's. Coming to the stomach, we have very good classifications available of magnification endoscopy of early gastric cancer from Japan, and if you see closely the gastric body mucosa, which is showing a regular marginal crypt epithelium, which is the pale surface, and then there is a pit, and which is surrounded by hexagonal capillary pattern. So you have to watch this, and based on this you can decide whether the microvascular pattern and microsurface pattern are changing to irregularity and absent pattern depending on the degree of dysplasia. So basically you have to see a demarcation line. As soon as you do a narrowband imaging of stomach, if you see a demarcation line, this is a 95% sensitive to catch the early gastric cancer. And if you see a demarcation line like this, which is totally, which can differentiate it between normal mucosa and abnormal area, and this demarcation line is not 100% specific. That means if you see a demarcation line, the cancer may be present or may not be present, then you have to go slightly in more detail once you see a demarcation line to see the irregular microvascular pattern or irregular microsurface pattern to clearly say that whether you are dealing with a cancer or not. This is one of our video where we can see that there is some surface irregularity, and it is very poor in detection but very good in characterization. So you have to depend on white light endoscopy to have a suspicion by seeing the irregular pattern, and once you see those irregularity or have suspicion, then you can zero down to that area and then you apply near focus or a zoom scope over there, and then you concentrate on the demarcation line. So this is the demarcation line which says that there may be cancer, but unless you see into the microvascular pattern, which is now clearly visible over there, which is irregular, and the microsurface pattern is almost absent. So this is a very early gastric cancer, undifferentiated type, where we can see this dilated corkscrew shaped microvessel. So a demarcation line and then going into the details is the best way to diagnose these early gastric cancer. I'll skip this because it is a treatment oriented slide. So coming back to the colon, and we have a very nice classification for classifying the polyps, but this is not magnification endoscopy based classification. This is the normal NBI based classification, which distinguish polyps into hyperplastic, adenoma and cancer, but it does not say about two things. We want to make this nice classification still nicer. If we have a hyperplastic polyp further characterized in sessile serrated adenoma, because nice classification does not talk about SSA, and second, type 2 adenoma can be low grade dysplasia and high grade dysplasia. So if you use magnification endoscopy, and then you will be able to answer these two questions. The type 1 is further classified into hyperplastic polyp or sessile serrated polyp, and type 2 is further classified into low grade intramucosal cancers when the vascular pattern and surface pattern are regular, and when they have further divided based on this microvascular pattern, which is only seen by magnification endoscopy, then if you see these irregular microvascular pattern, you can say that this cancer is now a high grade dysplasia and might be invading submucosa. So this is the Japanese NBI GENET classification, which classify these polyps into further. This is the hyperplastic polyp, and you can further see that this is a very small polyp with very small black dots available. This is hyperplastic polyp, and then hyperplastic polyp is further can be seen by this classification. And if you see this cloudy appearance, indistinct margin, lacy surface vessels, and these pits which are more prominent, they are the classified as this type 1 is classified as sessile serrated polyp. You can see these dilated crypt orifice, these surface pattern. So this is the difference between the NICE classification and Janet classification. They have further characterized type 1 and type 2. Type 2, you can see this is the adenomatous polyp, which is darker than surrounding. The vessels and microsurface pattern are regular. So this is adenoma, low grade dysplasia. And as you see the further classification, this is a polyp which was in NICE classification is still classified as type 2. But here this is a depressed lesion, and with the microvascular pattern and microsurface pattern are irregular. So this is type 2B. In a polyp, you have two different zones where you can classify this. So this is the beauty of magnification endoscopy, where you can further characterize your polyps. So in nutshell, if you see, the magnification endoscopy helps us in differentiating squamous cell carcinoma. The value, there is a good evidence that you can diagnose squamous cell carcinoma as well as characterize squamous cell carcinoma. The evidence for Barrett's is not that great. Intestinal metaplasia can be easily diagnosed by NBI, and early gastric cancer, especially characterization, can be done, and polyp assessment, as I showed you, the NICE classification. So these are the three major areas where in magnification endoscopy has brought a big change in our armamentarium to diagnose. Coming to the last topic of endocytoscopy. The endocytoscopy is a novel ultra high magnification endoscopy technique enabling us high quality in vivo assessment of a lesion found in the GI tract with the use of intraprocedural stain. So this is very important that we will be using intraprocedural stain. And there is a lot of development happened between the 4th generation of endocytoscope. We used in 2003 or 4 the probe based endocytoscopy, which was fixed focus, and it will allow around 1.25 times magnification. But now we have integrated endocytoscope in a scope which allows you to do NBI, the magnification endoscopy, and in the same continuum you can do endocytoscopy. So it's a one source where you can do many things, and this endocytoscopy is now commercially available and is used for assessing the esophagus, the stomach, and the colonic lesions very easily. We are now doing it in esophagus. We are using it for squamous cell cancers, and this is basically a lever is available there which you have to turn, which will start magnification observation, and as you do a contact endoscopy, this will provide you ultra magnification up to 520 times magnification can be available, and you can study the do the endocyto observation at cellular level, and you can see the IPCLs which were very these are very nicely visible with this endocytoscopy. So basically you have to do intraprocedural staining, and this intraprocedural staining is known as CM double staining. C is for crystal violet. You have to use make one syringe which is equal to 10 cc of 0.05% of crystal violet, and then you have to add 1 cc of 1% methylene blue, and then take 1 ml of this in various syringe, 1 ml of the dye which you have made, the CM dye, and 9 cc of air, and then during the procedure you have to keep on insufflating the mixture of air and 1 cc of this dye, and wait for 30 seconds till this dye is taken up by the cell. You have to study the cell morphology, the cytoplasm and the nucleus, and there are various classifications available for esophagus which can clearly differentiate between the intraepithelial neoplasia from the squamous cell carcinoma from the normal epithelium. And this is an example which we used in the first generation endocytoscopy. You can see these are rhomboid cells with very small nucleus, and on the right side you can see the cellular structure is gone and the nucleus are swollen with high chromatin. So on the right side you can do a real-time diagnosis of squamous cell carcinoma without even taking the tissue sampling. So this is the beauty, and ultimately this will come once we develop a more evidence and more experience in diagnosing these cancer, not only the esophagus, the classification available for gastric as well as colonic cancer. I will not go into the details. I'll just show you this video, which is a colonic polyp, which looks to me like a type 2B adenoma on Janet classification. And you can see here, you are using this endocytoscope. This is the magnification, which can be done by the same endoscope. And then as you are studying the magnification endoscopy, you have to then put the dye as the method I have told you, and then keep on zooming the same endoscope, the same lever you have to keep on pressing, and then you will have a fantastic images suggestive of a colonic cancer in that polyp already developed. So with this, I'll come to end of my lecture and summarize that this innovative field of magnification endoscopy has been expanded over the years with various cutting edge technologies. The advanced endoscopic imaging has become a routine part of practice of most endoscopists. Magnifying endoscopy has proven to be a key modality for effective diagnosis of early GI malignancy, but it is not used because of lack of expertise and training. And to realize the benefit from these technologies, we need a more robust evidence as to their effectiveness. Thank you very much for your patience.
Thank you, Mohan, for that excellent overview on this subject of high magnification endoscopy and endocytoscopy. We come to our last talk this evening, and this is on a very important area that's coming up very frequently now, the use of artificial intelligence assisted endoscopy. And to talk to us on this, we have Professor Michael Wallace. Michael is actually currently the Fred Anderson Professor of Medicine at the Mayo Clinic, Jacksonville in Florida. He is one of the pioneers in not only endoscopy, endoscopic ultrasound, but very often identified because of his editorship of GI endoscopy. During the editorship, he's brought about so many changes in GI endoscopy and made it the forefront endoscopy journal in the world today. Michael is a very reputed researcher. He is, of course, outstanding endoscopist and a passionate teacher. We are very fortunate to have him this evening talking to us about artificial intelligence in endoscopy, a talk that everybody is looking forward to. Mike, thank you very much for coming.
Mute. I think everyone can hear me now. Is that okay?
Yeah, thank you.
And you can see my slides.
Yes.
Very good. So I will spend the next 10 minutes or so talking quickly about artificial intelligence. We'll focus primarily on polyp detection studies, but there are many other areas that we could speak about. So these are my disclosures. So I will focus my talk on really the most natural application of AI to endoscopy, which is computer vision and computer-aided detection. We often hear these terms of CAD-E, which is computer-aided detection, as well as CAD-X, or computer-aided diagnosis. There are many other applications, however, that are relevant to the field of endoscopists and gastroenterologists. There's radiographical image, auto report generation, quality metrics, natural language processing, but we won't have time to cover those today. So why has AI become so hot lately? For many years, AI has been around really since the 1940s. but we tried to teach it what we as humans were doing. We tried to teach it, for example, the JNet classification or the CUDO classification. And as a result, it was very slow and never really developed into a highly accurate system because of the same reasons that we struggle with the original human-based classification. So, for example, we might, if we want an AI algorithm to distinguish a cat and a dog, in the old days we would say that a cat has 4 legs and a tail and pointed ears and a flat nose, and a dog has these features, much like we would teach it the CUDO or a JNet classification. In the modern era of AI, we simply use what's called agnostic, often supervised, and in some cases even unsupervised learning. We simply feed a large volume of images of one entity, in this case cats, and another entity, dogs. And we simply label, the human says these are all dogs and these are all cats, and we ask the computer to learn the difference between the two, not necessarily using the same features that we as humans think that we are using. So here's an example of one of the most recent systems. This is the GI Genius system now being distributed by Medtronic. This is a polyp detection system. It runs in real time during live endoscopy, and as you can see, it's picking up this very flat, subtle lesion, as we would hope such systems could do. There are several systems now that are being studied. This is the first one now commercially available in Europe and throughout several other parts of the world. So we also talk about computer-aided diagnosis. You saw very nice images from Mohan using the endocytoscopy system, and there's also an AI system to classify those lesions. I'll focus today's discussion on the detection systems and the studies around those. So we started seeing this literature emerge just last year. This was the first randomized controlled trial of an AI detection system published out of China from Dr. Wang, as well as several other investigators. And what you can see in this randomized trial of 1,130 patients, that the polyp detection rate was significantly higher with the computer-aided detection. Adenoma detection rate was also significantly higher. Overall numbers of polyps, mean numbers of polyps, all significantly higher when using such AI systems. We now have just seen a second trial. This is from our group led by Dr. Alessandro Repicci. This has just recently been accepted and is now in press in gastroenterology. The second large randomized controlled trial, 700 patients, in this case using the GI Genius system from Medtronic. So in the main results of this trial, there was a very significant increase from 41 to 57% overall adenoma detection. Note that even high adenoma detectors at 41% increased significantly. This was previously not seen with many ADR studies where it was only the low adenoma detectors that improved. And this was across the spectrum of small, medium, and larger polyps, although it was not powered to detect larger polyps. And importantly, it was seen in both polypoid and non-polypoid or flat polyps, and in the right and left colon. This is a recent meta-analysis also from Cesare Hassan, Doug Rex, Alessandro Repicci, and myself and this team, looking now at 6 published controlled trials, all just in the very recent literature, showing a 47% relative risk increase, or 1.47 in adenoma detection rate. Note the consistency of these trials, all trials currently showing increased adenoma detection. There are several other obvious applications of AI. We're seeing many of these in the literature. They extend to Barrett's esophagus, early gastric cancer, colitis imaging, but also particularly wireless capsule endoscopes, endomicroscopy, and even physiologic devices such as manometry, pH-metry, and endoflip systems. I just want to show one of these trials. This was a very large trial done in Japan with a capsule-based system. 5,000 patients used in the validation step of this, and really quite remarkable data. So in the conventional reading, we're looking at per patient sensitivity and specificity, per lesion sensitivity and specificity, and just clinically significant lesion. So in conventional reading, sensitivity of about 88%. This was with multiple readers. In the convolutional neural network, or AI system, this approaches perfection. So 99.9% to 100% sensitivity and specificity. And what's really quite remarkable is the amount of time that is saved. As anybody who reads capsules knows, There's many thousands, tens of thousands of images to read. In general, it can take up to an hour or more to read all of those images. But with the AI systems, that is now down to less than 6 minutes with the accuracy that I showed you before. So I think to summarize, AI is very rapidly transforming medicine. GI is following rapidly in the footsteps of other fields and is very well suited, particularly to the computer vision application for lesion detection and classification, adenoma detection rate improvement, automatic report generation, and other measures. Thank you very much.
Thank you, Mike, for that fantastic talk, and I think you've sort of told us very clearly the role of artificial intelligence in this area. There are actually lot questions coming in. I think we have had about a viewership of nearly 2,000 people. So with the lack of time, what we'll briefly do is take up one or two important questions in each area. The first one is for Chris. Chris, you told us about different systems, Olympus, RDI, EDOFs, and of course the Elexo system from Fujinon, the iScan from Pentex. So if somebody is going for a new system, they want to buy, I know this is not a very easy question to answer, what should they do? What should they look at to see which system they should buy?
That's a very interesting question and also not an easy question for me to answer. Obviously, you know, almost all the equipments now are high definition, and you get one way or the other image enhancements, zoom functions, so all of them are there. It also depends on what sort of endoscopy you're doing and what is your pathology and what sort of patient mix you are. And also the budget and what is available locally. So I think most of these things are now available globally, and there's not a huge big difference in the systems. But my personal experience here has been using the Fuji system in the last 12 months, and obviously the Olympus narrowband imaging, which I've been using for a while. And these things have now moved on to LED light source. So I think that's one step ahead instead of using the xenon lamp. So I think that's where I'll be looking at the modern technology, LED lamps and the 4K monitor, because otherwise you are not really getting the best out of this endoscopy system.
Thank you, Chris. For Mohan, we have a question. Mohan, endocytoscopy seems to elicit a lot of interest. So we now have an endocytoscopy we integrated with the large intestine. What about upper GI?
So upper GI also we have the gastroscope integrated with endocytoscopes, and NOE has done a lot of work in diagnosing squamous cell carcinoma. In fact, they have classified the IPCL based on endocytoscopy also, and the IPCLs are much better seen with endocytoscope, and you can clearly delineate whether the tumor has gone, because the esophagus is the most area where the cancer spreads very fast. If the cancer is in submucosa and colon, it is still resectable, but in esophagus you have to be very cautious. As that cancer goes to muscularis propria, it's almost become the lymph node metastasis increase. So you have to be very precise in esophagus, and I think endocytoscope integrated gastroscope will be very promising.
And endocytoscope, I think, is a part of, instead of saying diagnostic, we call it interventional endoscopy, because unless you are using it for intervention, it doesn't have any meaning at all.
Of course.
I think this is part of the intervention. So, Mike, there's this question on artificial intelligence. I think there's a lot of excitement in this area. We see, actually, even in lay press, there's a lot of people talking about AI and endoscopy. These two important studies you showed us, one in gut and one in gastroenterology, which have shown its utility. But the question that's being asked is, how useful is it really? For example, the gastroenterology paper, how useful in the sense that it points out towards those polyps which can make a difference in screening. For example, if you miss a polyp, it may not make a difference at all. And just because AI is picking it up, it doesn't mean that it's going to make a difference in clinical outcome. So do you think AI is going to make endoscopy more different in terms of clinical outcomes?
Well, I think what we know clearly is that the higher your adenoma detection rate, the more protective that colonoscopy is for subsequent colon cancer. And that's across the spectrum of polyps. While clearly a 2 or 3 millimeter adenoma is probably not clinically relevant, what we're seeing is that it's detecting also the flat lesions. And it's these flat lesions particularly the sessile serrated adenomas, where I think it makes the most clinical difference, because those are the lesions that are likely to progress onto cancer in the next 5 or 10 years if they're missed. We did in that trial actually detect we detected more cancers. We detected 10 cancers in the AI arm and 3 cancers in the non-AI arm. Now, it was not powered to detect that number significantly, but it was a numerical increase in the overall cancer detection as well. But I think the key is that the more adenomas we find overall, we know from many studies that that's going to reduce the risk of a subsequent interval colorectal cancer.
And this Genius system from Medtronic can be put into any endoscopic system. You don't have...
That's correct. It's a standalone box. It just has a video in and a video out feed. Goes with any endoscope.
Yeah, so that's an advantage, I think. So actually we have a lot of questions coming, but I think we have already crossed our time. It's 6:32 here now. I like to thank all our speakers for the excellent talks that they're given, and of course I think we've been enriched by these 3 talks that we had this evening. So Chris, thank you very much. Mike, thank you very much for being with us this evening, and Mohan, thank you.
Thanks, Nagi, for hosting it.
Thank you. A wonderful day.
Thank you.